Welcome everyone. The webinar will begin in about 1 minute. Okay, so welcome to the Leukemia and Lymphoma Society of Canada's webcast, Managing Multiple Myeloma, How Emerging Therapies Can Help. In this webcast, Dr. Sharif will provide an overview of multiple myeloma, as well as review the current and emerging treatment options. So let me introduce myself. My name is Sonia Muto, and I'm the Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. The presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. I will read some of your questions out loud at the end of the presentation during the question and answer period. The conference will also be recorded, so therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that might be helpful for you or someone that you know. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. Next slide. We know the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by blood cancer cope with anxiety and isolation during these times. Please do not hesitate to contact a community services manager in your area. We also invite you to visit our COVID-19 Resource Center for up-to-date information. Next slide. As part of Myeloma Awareness Week, I invite you to visit our website to read testimonials, watch animated explainer videos, and download our new information fact sheets and our booklets on myeloma. Next slide. On our website, you will also find recordings of all our previous webcasts that you can watch at a time that is most convenient to your schedule. Next slide. Subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatment and research and to hear stories from people affected by a blood cancer. Available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your favorite podcasts. Next slide. Our peer support program is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by blood cancer and share similar experiences. Whenever possible, participants and volunteers are matched based on their age, gender, and diagnosis. It can be a useful program these days to counter the effects of isolation. Next slide, please. So it is my pleasure to introduce our speaker today, Dr. Ismail Sharif. Dr. Sharif is a fellow member of the Royal College of Physicians and Surgeons of Canada. He is currently an assistant professor at Dalhousie University in Halifax. He completed training in internal medicine and adult hematology at Dalhousie University, as well as completed fellowship in myeloma at the University of Toronto in 2019. His interest is in malignant hematology area of focus in plasma cell dyscrasia. Over to you, Dr. Sharif.
Okay, thanks Sonia Madu for introduction, and also would like to thank the organizers for having me be part of this presentation during the Myeloma Awareness Week. So I will try during my presentation to cover basically what we mean by monoclonal gammopathy, and also pathophysiology, and then we'll cover the diagnosis, and then also we go about the treatment, criteria of response for those during these treatments, and then management also for patients who do have a relapse of the disease. So this is about this slide here just to show the way how these plasma cells, they look like. So multiple myeloma is one of the plasma cell neoplasms. And to know about multiple myeloma and how developed or any other of the plasma cell dyscrasia, it's good to look back and how these plasma cells are. So plasma cells are actually a type of white blood cells. They're lymphoid lineage, we call them. They are responsible for producing immunoglobulins that they do help fighting infections, okay? So usually they are what we call polyclonal, okay? There are many of them. If you see these colors here, they can be many different colors. At some point, patients who develop the disease or plasma dyscrasia, they develop a monoclonal, basically just one clone developing of plasma cell that's growing fast, more than the others. It's like if we look at our testing, how we detect this, one of the tests is what we call serum protein electrophoresis. If you see in the left lower corner there, this is a normal test, okay? We see the immunoglobulins, how they come, and this is the normal wave of it. But patients who have an abnormal M protein is that when they develop this kind of spike. So they have a monoclonal plasma cells producing the M protein. So number one, I'd like you guys to remember, is the M protein that's coming from these monoclonal plasma cells, because it's an important part where we follow this disease. So plasma cell dyscrasia, it's a more than one disease, can be either in the category how it progresses or some variant types of it. So like MGUS, a monoclonal gammopathy of undetermined significance, or it can be a myeloma. There's also plasma lymphocytic lymphoma, or Waldenström macroglobulinemia. And then there are also amyloidosis and also POEMS syndrome. Okay, these are also plasma cell dyscrasia and also are considered malignancies or cancers as well. Now, multiple myeloma, unfortunately, it's an incurable disease so far, but we're looking hopefully in the near future, this will be concurred and we're moving that way, because certainly treatments has been improving significantly over the past couple of decades. Managing myeloma, and we're seeing as a great success. Percentage of patients, it's about 1% of all cancers and about 10% of hematological malignancies. Age of patients usually vary between 65 to 70. That's the average when we see this. Yes, we can see it in younger patients or older patients. The most important part of diagnosis is having those monoclonal plasma cells and having the M protein for diagnosing multiple myeloma or plasma cell dyscrasia. It can be in the serum, detected by a blood test, or it can be in the urine. And then this protein can accumulate and cause problems. So just to say here how the start of the disease can be, okay? It can, as we said, the MGUS, which is basically a monoclonal gammopathy of undetermined significance. It's a start of the disease can be with developing the M protein. It will be a very small amount of it at 3 grams. And for those patients, if we do a bone marrow biopsy, we'll find that it's less than 10% of abnormal cells, these abnormal monoclonal plasma cells. And they don't have what we call an end organ damage. So those patients, they can progress at a 1% per year, okay? Then in the middle, what we call a asymptomatic multiple myeloma or smoldering myeloma. These patients, they don't have the symptoms yet from the multiple myeloma or don't meet the criteria diagnostic of multiple myeloma. Then at the end is the multiple myeloma. So meaning those patients, they will have the M protein, but we prove also by a bone marrow biopsy or biopsy from what we call plasmacytoma, so nodules or lesions of myeloma, to prove and show that there's a monoclonal plasma cells, and in the bone marrow to be more than 10%. Now, the myeloma can be a patchy disease in the bone marrow, so it's always good to correlate all the symptoms together, and when you do the bone marrow biopsy, we look at the percentage. Now, then when we have the monoclonal plasma cells, there's the end organ damage that happens for those patients with myeloma. what we call CRAP criteria. It's basically patients that can have a high calcium, okay, more than 2.7. They can have a kidney failure of creatinine. This is what we measure the kidney function, be more than 177, or they have anemia, which is the hemoglobin that gives us energy, okay, or they have bone lesions. So I'll go briefly on around the epidemiology and basically what's the incidence here we have in Canada for myeloma, and then what can cause myeloma. So distribution, if you look at the map here, in the green, those are the numbers for the 2016 of multiple myeloma, and the orange is 2019. So you can see the total greens basically across the country, probably 2,700 cases, while in 2019, 3,350. Yes, it looks more. The incident is that because diagnosis more is, are we basically patients are living longer, so we see patients diagnose them with multiple myeloma, or is there risk factors that increase in causing this? So if we look at the incidence basically in population, it's about 7.8 per 100,000 patients can develop multiple myeloma. Is a 1.3 to 1.7% of total the new cancers as in 2019. So if we look at the demographics or the factors of multiple myeloma, is patients with age, as we mentioned, higher, between 65 to 75, those are the highest patients. This basically tells the older we get, the more likely we develop myeloma. Patients who had MGUS before, or patients who have a family history of multiple myeloma. So yes, there's some evidence linking that is heredity there. And then also some evidence that maybe those family members were exposed to similar substances in their lifetime. That's why they have increased as well. Some ethnicities, like African or African American ethnicity, they have a higher incidence of myeloma. Now, environmental factors like radiations, yes, it does increase, about threefold increase of multiple myeloma. Pesticides or herbicides, those agents do increase the incidence of plasma cell dyscrasia. Or airborne carcinogens can do also increase that as well. So in the background, just to remind you again, the bone marrow, as I said, produces stem cells. The stem cells, which is the white blood cells, then they can happen. There are two lineages, we say, two important categories of the white blood cell. There is the myeloid, and this lineage can happen from an AML or other disease, and then lymphoid, which can happen from the lymphoma and the myeloma. Then the lymphoid, we have a small lymphocytes can develop B cells, and that's from it that the plasma cells happen, okay? So that's how the lineage happens. So those are the cells that plasma cells, if they become abnormal, they develop multiple myeloma. So when these plasma cells start growing in the bone marrow, that's how they lead to the disease. If they growing significantly in bone marrow, then decrease the healthy cells from production, like a red blood cells, so develop anemia. They can increase until they start causing cracks in the bone, then causing lytic lesions or bone fractures. And also they can produce significant protein that eventually would lead to damage to the kidneys or kidney failure. Now, multiple myeloma as a disease with the abnormal plasma cells in the marrow is actually, it goes in a vicious circle. It starts developing, affecting what we call stromal cells in the marrow, causing some effect on the suppressor cells or growth factors, leading to affect and decrease immune function. And this failure in the immune function gives these cells strength to grow even more because there's no immune function stopping them. So multiple myeloma is a disease affecting multiple components, okay? So we'll try to attack it from different angles when we treat it. So when there is some myeloma cells, there's increased cytokines and growth factors, and there's effect on the stromal cells. And then also, as I mentioned, the immune dysfunctions get affected. So this is then, it gives them a more power that they can grow. So Then manifestation, I just went through about a little bit, so I'll emphasize on it. So the bone marrow biopsy aspiratin, this is what we do to diagnose any patients with multiple myeloma. It shows here the two pictures. If you look at the picture on the left side, shows you a normal marrow. If you look at the picture on the right, you see more blue cells around here. So these plasma cells, these are the plasma cells producing the protein. They're supposed to be polyclonal and less than 5%. But if you see, it's easy to tell on the right side, oh, it's really increased. So these, as they grow more, they make the red blood cells, other cells go low because they're growing more. So you develop anemia, patient feel fatigue. They grow more, they crack in the bone marrow on the sides. So as I said again, the CRAB criteria is the diagnostic feature of end organ damage. The hemoglobin goes low, patients feel fatigued and tired. Kidney function, patients developing high calcium because of the cracking on the bone. It leads to increasing calcium, which can has its manifestations, including like affecting bowel movements, can cause confusion. All these can be related to the high calcium. And then the bone lytic lesions. The other tests we do, as I said, serum proteinuria is the one test. It is important for myeloma, and it's what shows us the M protein. There are other tests like beta-2 microglobulin. This helps us with the prognostication. And then imaging, skeletal survey is the most what we do, but sometimes we might need an MRI or PET scan to further categorize disease. Now, I mentioned about the CRAB criteria for multiple myeloma, but since 2016, there is another criteria added to diagnose multiple myeloma. Because there are some patients who come to us with having a high protein, but they're feeling tired. But if you look at their numbers, the hemoglobin, the kidney function, the calcium, doesn't show that they have what we call the end organ damage, okay? So we can go further to stratify those patients because sometimes looks like the immunoglobulin is high, the M protein. So we go in and do a bone marrow biopsy because if we find that they have a more than 60% of abnormal plasma cells in the marrow, that's enough to call the patient to have myeloma, even if they don't have the end organ damage. Or there's a serum free light chain. We look at the free light chains that's involved over the uninvolved. If we divide them, it comes more than 100 that says this patient has myeloma. Or sometimes the patients are not meeting the criteria and the skeletal survey is not showing much, the patient looks symptomatic and the M protein is high, we do a PET scan or MRI, which can help us further confirm diagnosis that meets with this new criteria. I recall also slim CRAB. Now, imaging, it's basically the skeletal survey is what we start with always, but sometimes patients having pain or sometimes there are concerns about biochemical markers are high and we need to confirm there's no bone involvement. So we do a low dose whole body CT, very helpful. It can pick up findings and not significant exposure radiation on it. And then the next is PET scan, possibly because it covers everything, or sometimes even MRI to confirm the findings of multiple myeloma. Now, this is a very common question, okay? I get from my patient is, okay, what's my disease stage? Okay, so blood cancer is usually it's spreading everywhere. It's not at one location, okay, in the bone marrow and going everywhere. So, but there are some staging system that helps us telling about the disease status or prognosis. This is an old staging system, ISS, basically depends on the end organ damage and also immunoglobulins. So, and then the international staging system, basically patients, so we do beta-2 microglobulin, we said, and also albumin, and we call them stage 1 if the beta-2 microglobulin is less than 3.5 or and the albumin is more than 35. Those, they would have a median overall survival of 62 months. If there is one of them that's abnormal, mainly beta-2 microglobulin, is 29 months. Sorry, that's stage 3. If the beta-2 microglobulin is more than 5.5, then median overall survival is 29 months. But at stage 2, if either one of them is abnormal, neither one of them, so then we called 44 months. Okay, so that was the prior what we used to do in the past. But we have been learning more and more about myeloma over the past couple of decades. And we've been doing the FISH testing in the bone marrow or cytogenetics, okay, to find more about the genes. And we found that there are some genes actually associated with a more aggressive form of myeloma, or others are standard risk of myeloma. The patients are doing well and having longer survival and response to treatment. Like hyperdiploidy, having more than one chromosome increase, or there are patients who are having translocations, so like translocation 414, 1416, okay, 1420, and deletion 17. Those are considered a high risk or bad markers. Now, so based on this gene testing, then came back the revised ISS, so they revised the International Staging System for myeloma. So again, stage one, they're incorporated with the staging, not only the cytogenetics, but also the beta-2, the albumin, and the LDH. So that's why the first time we diagnose a patient, we want to do a lot of testing and make sure that we have a baseline on the stage. So we do the albumin, beta-2, microglobulin, and the LDH, and then we have the bone marrow syndrome for cytogenetics. And once we have all together, then it tells us about the prognosis and stage 1, 2, or 3. And this gives a rough estimate about the 5-year overall survival. Basically, patients who have a stage 4, which all of them, they have a high risk cytogenetics, either 414, 1416, or 17, then this is a 40% to 5-year survival. So based on this, we can have prognosis. Now, the cytogenetics abnormalities, hyperdiploidy always looks at the favorable outcomes. The high-risk cytogenetics looks at adverse. The translocation 1114 is a risk neutral disease. So we'll talk about now the treatment of multiple myeloma. So just to recap, we talked briefly about the physiology, about the disease, how it develops from MGUS all the way to myeloma. And then we said how we diagnose patients with multiple myeloma. As I said at the beginning, is the M protein to have it there, and plasma cells in the marrow more than 10%. And we said one of the end organ damage is either anemia, hypercalcemia, renal failure, and bone lesions, which can be from skeletal survey or MRI or PET scan, because there's also what we said, the slim crab. So now once we confirm the diagnosis of multiple myeloma, then we go next to the treatment. So I'll go a little bit first about the history of the treatment. So we have big gains has been made in the treatment of multiple myeloma. If you look back in the 1950s, and then in the 1960s, we start the prednisone as steroids, and then the melphalan came, which is very good old melphalan, still around with us, and we're still using it since 1957. And then the auto transplant came in, and then start the other drugs popping up, the bortezomib and carfilzomib, and then immunomodulators like the lenalidomide and pomalidomide, and now even more therapies coming as the ixazomib, and then the monoclonal antibodies like the daratumumab, alemtuzumab. So all they're coming. So if we want to look at the treatment, it's, as I said, it's a disease, has multiple components, so we need to look at treatment from multiple sides, okay? So at first, there's always an induction therapy, okay, as in first to decrease the disease. But then we look at patients who can go to transplant route or patients not transplant eligible, okay? And then we'll take each side as it goes. Along with the treatment for myeloma itself as well, we need to focus also on supportive care, because patients come with bone aches or fractures or kidney failure, so we need to support that part, either with pain control, fractures, sometimes vertebral fractures, we talk about kyphoplasty, and sometimes also we need to consider what we call bisphosphonate or zoledronic acid, which we use to help with bone rebuilding. So we'll I just have a small algorithm here about how we look at it and managing myeloma as transplant eligible route or non-transplant eligible route. Age has not been really specifically really fixed across the country, I would say, and patient's performance is really important and a key factor when we decide, and also comorbidities. So if patients are eligible, then we do induction, then auto transplant, and then maintenance. This is a one-step treatment. Then we continue until patient progress. Patient transplant eligible, and basically we go with the induction treatment. We used to do a VNP until recently when it came Dex, and other therapy like RVD now. So, and then when patients relapse, we have other treatment. So I will take each one briefly, and also I'll try to mention in a very simple ways just to show a little bit of the medical evidence and how this is coming and building in. So first, to say when we see the patient first time is the determination of which route to go, which one is transplant eligible, and who is not. So age is, we still look at it as age, just a number. Performance is important, but sometimes going up and up higher than 77, it's unlikely to see, but still we have seen patients who we did transplant even older than that. The liver function or organ function in general, okay, the ECOG, which we call it, is a performance status. And we'll just say briefly, what does 3 and 4 performance status mean? It's basically 3 meaning a patient spending all their time in their bed, they're not moving. And that's should not be from disease, from itself, from myeloma itself. Could be other factors. This is this patient's performance status. Okay, patients who have a fracture in their back and they cannot move, we cannot really consider it as the low performance that they cannot move. That's why we're not going to consider them for transplant. And then patients with New York Heart Association functional status 3 or 4. So depending on their heart function, it's a very important and crucial part of the treatment. So patients who have a poor heart function that we don't typically take in transplant. So the treatment or therapeutic agents, there are number of them, and actually the list is growing. Okay, so the simple ones, I'll just put them here in categories to show you the class of each one, and that's why the combination we talked earlier, the myeloma, we need to attack it from more than one side. That's why you're not going to see same class 2 drugs are used. So we usually mix them from each class. Okay, so steroids, dexamethasone is the most used in all regimen, but sometimes some patients don't tolerate dexamethasone, so we switch to prednisone. Sometimes patients who are very sick in the hospital cannot eat, we can give them IV steroids as well. Cyclophosphamide has been, it's an alkylating agent, has been there for a while. We've been using it, many regimen on it, and it does really make a difference. And then melphalan, we know. Then we have what we call proteasome inhibitors, like bortezomib, which is the first one in the kicking in the those novel agents. It started as an IV. Now we're happy to have it a subcutaneously. And then there's the carfilzomib, the same class. Okay, it's given as an IV. And then we have the ixazomib, which is an oral regimen, oral pill. Then the immunomodulator, thalidomide, lenalidomide, and or the Revlimid, and basically the pomalidomide or Pomalyst. Okay, and then there's the newer ones that are coming. They're here already now, but they're even making it higher and higher on the scale of the treatment. The daratumumab, the elotuzumab, and then now the newer agents we have. Okay, there's the antibody conjugate antibody. So this is what we have now. We see it in clinical trials is the belantamab mafodotin, and this is coming in the near future. We'll watch how the clinical trials will unfold and go. Other drugs like BCL2 inhibitor, which is a more target treatment. This is being used in other types of blood cancers, like CLL specifically. And it's a target can go in the translocation 1114. So there are trials now enrolling across the North America and Europe for venetoclax. And then there is the BiTE therapy, which is the bispecific T-cell engager therapy. It's a therapy treatment. The way it works, it does help to hold the T cells, which are part of our immune system, and then hold the myeloma cells, try to make it attack it to basically degenerate or kill these plasma cells. And similar to the BiTE therapy, but it's not off the shelf like the BiTE therapy, it's the CAR T cell therapy, which is a treatment. Basically, I call it reverse transplant sometimes. It's basically you take the cells, you don't return the cells back, you just take cells from a patient and send them to manufacture to engineer them, fix them, to help them attack these cancer cells and put these cells back into the patient then. So these are all the classes of therapy. Now, I'll take them one by one and quickly on studies here. And basically, we said we choose for patient induction. This is what we do across the country and North America. Is Cyborg-D is the regimen that we use for patients who are transplant eligible. So, and their studies shows that its efficacy and it's a good regimen with a high response for patients to go on for transplant. So with this study said that patients who are post the 4 cycles, they have a very good response with a CR rate, meaning complete remission. It goes to 46% almost, and even post-transplant can be 70%. Now, those patients, we give them Cyborg-D after start. Basically, Cyborg-D, we give 4 to 6 cycles sometimes, and then as the patients respond, then we go to the next step, which is the transplant. And we know transplant, basically, we take stem cells from the patient, we give them a very high dose chemotherapy, and then give them back their stem cells and help that the healthy cells will grow. And then now, unfortunately, when we take the stem cells, turn them back, there's no way for us or learn yet to say we can take these plasma cells left there. So unfortunately, there's always will be a plasma cell. So as always, then there's treatment needed to keep those down. So that's why the next step is maintenance after the transplant. So here's another question I get, kind of like, okay, why do I need to get maintenance if I got transplant? So this is just a small diagram to show you that maintenance, it does make a difference. And just focus on this here. So patients who take maintenance, about 53 months longer having it time to progression as compared to patients who did not take maintenance, 26 months. So easily answer, I put in my patient, I say it doubles your time after a transplant from the disease coming back, okay? Okay, so that was for the patients who are transplant eligible. Now, what are non-transplant eligible? So here, I think most of the provinces across, we do have those patients as a Revlimid and dexamethasone, or lenalidomide dexamethasone, the immunomodulator that's we use as a frontline therapy. This is what all provinces say they have access to. And this is the first trial, one of the trials that showed the really good treatment for those patients. And basically, if you look at the green line here, it's showing the Revlimid dexamethasone, and it's showing it's 25 months as compared to patients just stopped after 18 months, or patients who have melphalan, prednisone, and thalidomide. So that's where those treatment that we offer to our patients here, from cyclophosphamide, bortezomib dex induction for transplant, and that's where the Revlimid dexamethasone treatment came from. So that's why we go to it and say this is a really good frontline treatment for our patients. Now, after patients start in the frontline, we do blood work almost on a monthly basis to watch their myeloma and how it's doing. So as I mentioned earlier, is the important thing to remember is M protein. And this is one of the most important things we watch for patients' response, along with others, but this is the most important. So the response is divided in categories. Patients who have what we call stringent complete remission, or SCR. Okay, this is basically the M protein, we no longer see it, and the bone marrow is very clear. Okay, now complete remission, yes, the M, if we do serum protein apheresis, there is no M protein, and if we do a bone marrow, then it's less than 5%, okay, of plasma cells in the marrow. So this is what we call complete remission. And then we have a very good partial remission. It's basically 90% of the response. What we call partial remission is more than 50%. Minor remission is 25 to 49%. Stable disease, or progressed disease. So progressed disease, after we treat our patients, we're doing treatment and patients going on this treatment doing very well. But once we see there is a 25% increase on the M protein, we see, unfortunately, this is biochemical relapse, we call it. So these are the criteria we look what we're doing, and that's why we do blood work on a monthly basis. So myeloma, once get diagnosed, just to show here, patient got diagnosed, then we start treatment, we get them down to remission. And then after a while, unfortunately, patients start 25% increase, this is relapse. So then we try to get them back in remission. Unfortunately, usually the remission is not as good the first time, and then go on, relapse again, you start treating again. Unfortunately, until the end, we lose control of the disease. And why is that? So there are findings now with more and more investigations that we're developing, like a minimal residual disease, that's a little bit of blood, a little bit of myeloma can be left in, and this is testing coming in the future. Right now is not a standard in the practice. So in the disease, why each time it relapses becomes more difficult, because there's what we call clonal evolution, or more clones developing and becomes harder to control. So I mentioned about the treatments earlier on my slide table about many different types. So what can we do with our patients who relapse? So always combination therapy is good to go after aspects of myeloma from different angles we hit it. So the daratumumab monoclonal antibody, either with Revlimid dexamethasone or daratumumab bortezomib dex, is a very good regimen. Then we have also pomalidomide bortezomib dex, carfilzomib dex. Now in the clinical trials, only panitumumab mofedatin. There's also selinexor in clinical trials as well. And then BiTE therapy, it's an anti-BCMA antibody, also clinical trials and CAR-T. Now, just here to review quickly about the regimens, just to show how these come into overall response. So ixazomib, Rev, Dex together shows about 78% overall response. KRD about 87%. Elotuzumab, Rev, Dex 79. Daratumumab, Rev, Dex, which is one of the good regimens we have, is 93%. Daratumumab, Velcade, Dex 83. So these are, remember, just not comparing head to head. So each study is in its own. So each drug that we can offer for relapse disease, I'll come through where study comes quickly for it. Daratumumab, which we can do it as depending on what patient had before. Daratumumab with Revlimid Dex, just like here, and shows us when we add the daratumumab to the Revlimid Dex as compared to Revlimid Dex, the purple line shows how the median survival is better at 38 months compared to 18. And then the daratumumab Velcade Dex is showing 9.5 months compared to 6.1 months. So that was the daratumumab evidence. Now, what about the carfilzomib, which if patient never had Revlimid, we can consider doing KRD, or and then comparing KRD to RD, it shows the red line is patients who had carfilzomib. It shows their progression survival, proportion of their survival without progression compared to the RD alone. So certainly adding carfilzomib, it adds up. Then also, if patients have had before Revlimid or other agents, which we cannot use with carfilzomib again, carfilzomib alone with dexamethasone as compared to Velcade in those patients, it shows also a good improved response in basically 18 months as compared to 9 months. Termlines, another study looking basically for patients who are getting ixazomib, okay, which is another proteasome inhibitor, and compared to placebo group. So it shows that ixazomib arm in the Termline study gave it 20 months compared to 14. Now, as I mentioned, like the daratumumab with other agents usually comes on the relapse, and then the other options after or carfilzomib, and then the other options is the pomalidomide also is an option, which is like a Revlimid. It's a pill as well. We give it every 21 days on a week break, and then keep on going. So the pomalidomide with Velcade and Dex compared to basically Velcade and Dex alone, it shows, yes, it does have some improvement in the progression-free survival for those patients, 11 compared to 7 months. Now, there's also then another study, and that's when we coming down on the line. So we're talking down about third, fourth line. There's some study has been published recently. Many Canadian centers has had this study has the agent. It's an oral therapy, Selinexor. Okay, so Selinexor, it's a good drug, and it's a triplet with the Revlimid and Dex showed to be a very highly effective and tolerable treatment. It can be overall response about 60%. So Selinexor is one of the new drugs coming. Now, okay, what are the others that when we're talking about beyond the second or third line of therapy? There are studies now ongoing for these therapies, and most of the patients who are enrolled in these treatments are not frontline or not first line. They're basically in relapse sitting on the third or beyond the second line. So basically, and one of these therapy is the CAR T cell. And as I mentioned, CAR T cell is basically it's engineered by taking the cells from patients and void cells and then sending them to the lab to engineer those cells and then send them back to be infused to the patient after conditioning treatment. So those treatments, there are more than one study coming now so far, and it's showing there is efficacy. On average, maybe there was a between 10 to 14 months of most of the trials that I have looked at for the CAR T cell. There are some side effects and complication with it, and mostly there's something called CRS, okay, which is like almost as similar to it's a serotonin release syndrome for those patients, and can be a serious complication. Also, a neuropathy as well can be serious complication as well. So the other treatment then that's coming in, there are more clinical trials now for beyond the second line of therapy coming and showing results, is the BiTE therapy. And these BiTE therapy there are many agents, and most of them, they are anti-BCMA. The anti-BCMA it's an expression, it's found on the plasma cells. It's expressed on plasma cells. We call them a CD138. So the BiTE therapy, it goes directly to make those plasma cells connected close to the T cells, so it attacks them to kill those plasma cells. So it's a selective agent. It's very good. It's targeted immunotherapy, basically. So very, very aid in the study. There are phase 1, phase 2s are ongoing as well. So this is still early. The median overall response is basically progression-free survival of 12 months. So just to recap here, so yes, the second line funding, and I think this is in most across the country here, we have the daratumumab second line plus the lenalidomide and dexamethasone. As I said, like the thing here, the Revlimid is used most of the time for patients as a frontline, that's RD, patients who are not transplant eligible, and also can be used or already used on patients who are transplant eligible as a maintenance. So we end up using daratumumab, Velcade, or bortezomib dex. And then the carfilzomib is an option. You use carfilzomib dex because we've used the LEN. And then the POM is the one that's funded. But now there are agents coming to be used with the POM as a triplet. So with all of these developments, so that's very good. And we see survival for patients, standard disease, and even the high risk. They're improving all across, and patients are doing much better, living longer. And these therapies are good and proven, and it also there are costs for these therapies. So and I'm hoping to see these costs go lower and lower as those drugs go generic. Like we know Velcade, when it started more than like 15 or 20 years ago, was very expensive. Now it's coming down in the cost. So eventually, I'll say here, there are many treatments coming from multiple myeloma. Certainly, we have made a lot of gains in treating multiple myeloma. Hopefully, cure is just around the corner for multiple myeloma. And if we look in this slide, it shows there are many other options of therapy that they are coming. There is in a phase one, most of them in phase one clinical trial, meaning it's a very early study, and then studies, so it moves from phase one to phase two. Then if the drug is doing much better, then it moves on to phase three. Of course, each level based on the dosing, how to adjust for the dose, and how patients respond and safety assist. So these drugs, like the vaccine therapy, there are CAR T therapy, and there are also some more immunoadjuvant therapy that are coming. There are also some immuno checkpoint inhibitors or other class of drugs that they're coming as well. And there are more newer to the list I could add here, immunomodulator, like an EBER therapy called. There are, I think, trials almost across the country. They're available now. From monoclonal antibodies, there's the avelumab, we know daratumab, but also there are other monoclonal antibodies, anti-CD40, CD55, and all these are in what we say the pipeline. They're coming in the near future in the clinical trials. So this is very encouraging. This is very great news to see, and hopefully continue on to see our patient myeloma doing much better and eventually conquer cure for myeloma. So I think this is all what I wanted to present here today, and hope that I wasn't going too fast and I was at the level you guys can gather information from it. And I wonder if you do have any questions.
Yes, thank you. Thank you so much, Dr. Sharif. We actually did receive quite a few questions. So I just want to remind everyone that if you haven't already done so, you can please use the Q&A box of your Zoom webinar panel to type your question, and we will do our best to get to as many questions as possible during this Q&A period. During the presentation, I received, there was 2 questions that actually were just looking for some clarification on what you presented. So I'll probably start with those. So at one point in talking about the different treatments, you mentioned 12.2 months versus 7.1 month. And an example was PVD versus VD. Does this mean how long the treatment will keep them from relapsing, or does it mean something else?
So it depends. Probably the progression-free survival basically from relapsing time. That's what, for that study specifically. Yeah.
Excellent. Thank you. There was one more clarification request. Is M protein the IgM protein? Is that what?
Yeah, so that's a very good question. I should have clarified a bit more. So basically, as I said, the plasma cells produce IgG, IgA, and IgM, okay? And basically, the M protein, it actually develops within one of these, okay? So if you recall the first slide showed serum electrophoresis, it showed the jump for the IgG, then IgA, IgM, but a patient can develop M protein. We can classify it as IgG kappa, for example, or IgG lambda, or IgA lambda. So that protein will be embedded within inside. Okay, I was wondering if you can pull up that slide again, but
yeah, you can go back and go ahead.
I don't know how to go to the first. Next slide. End slides shows. Okay, here. Maybe easier this way. Start from the beginning. Yeah, this one here. So Yeah, so if you see here, these are the protein that are developed that plasma cells normally produce. And let's say this is where you see number one here. Let's say this is where the IgA is residing. Okay, so then when patients develop IgA kappa monoclonal protein, it will look like the IgA goes way higher. So then when you take this out and analyze it, you find it's a monoclonal protein hiding on the IgA kappa. Okay, so it's not IgG, it's not IgM. Sometimes this high number one could be hiding here, it could go much higher here. So then it's called IgG, whatever it was, kappa or lambda, it can be here, though this go very much higher. Okay, I hope that explains it. So, but just to say, yes, you might look at your IgG to be very high or IgA to be very high, but look at the analysis or report of the M protein, what it is specifically. Now, interestingly, you asked IgM. I'll just say the Waldenstrom disease or lymphoblastic lymphoma, it is the most common IgM monoclonal protein. It's very rare to see myeloma that's IgM. However, you can, but it's very rare.
Thank you so much for that.
Okay.
Okay, so we do have quite a few questions. Can myeloma be triggered by multiple skin cancers over a long period of time?
So the short answer is no. Basically, not other cancer can cause myeloma. Okay, but basically patients who have decreased immune function, they will be at risk of developing other malignancies.
I guess that would actually lead into the next question. So what are the similarities between myeloma and AML? So after AML with a stem cell transplant, is this person susceptible to myeloma?
Yeah, so myeloma and AML both are blood cancers. However, each one of them is coming from a different lineage. If you say AML comes from this side, from the myeloid lineage, while myeloma comes from the lymphoid lineage, specifically the B cells. Okay, so they're totally different diseases. Okay, now the question about can myeloma happen from AML? No, it's impossible. Can they coexist? It's very unfortunate. Okay, but can patients with myeloma end up developing AML? Unfortunately, this is one of the side effects of the chemotherapy and specifically the high dose chemotherapy for auto transplant, because lots of patients with myeloma get an auto transplant. They will have an increased risk of having a secondary malignancy, specifically AML or ALL. The other thing to mention also, there are some treatments we use, and specifically that's the Revlimid or Pomalyst. Those can have, I would say, a very small risk of having a primary secondary malignancy. It can be on the line of 3%. Okay, so I always tell our patients, yes, there is this risk after many years, but here the benefit outweighs risk. The benefit of the drug is more important.
Thank you.
Okay.
The next question here is, if you're a dialysis patient, can you get a stem cell transplant?
Yeah, this is a very good question, and always I would say this is best to be assessed by the hematologist who is assessing this patient before treatment, before transplant, because it can vary from a patient to patient and who can go transplant. Ideally, if a patient is a renal failure secondary to his myeloma, not happening prior to that, and just developed the renal failure and dialysis because of the multiple myeloma, and if the otherwise patient is fit, I would consider them for auto transplant, even if they were still on dialysis. Okay, but certainly would be a high risk procedure, and certainly they will need to have modification of their treatment for the conditioning for the transplant. And the thing here is to be aware of, and unfortunately sometimes if patients' kidney function do not improve and do not respond to treatment, getting off dialysis because treatment of myeloma, it becomes the chances are slim when we do a transplant. I have seen one case so far that after the transplant, they actually end up remission.
Thank you. I have a few more questions here. So is amyloidosis considered a blood cancer?
Yes, that's a good question, and always comes up. And is it a disease or a cancer? It's a plasma cell secretae, and yes, it is a cancer like the amyloidosis, Talm syndrome, or also myeloma and or lymphoblastic lymphoma, Waldenström disease. Those are cancers, malignancies. Yes.
Another question: what is the best food to eat or diet?
It's a very important question, and that's basically always the patient's part with encouraged from the medical team. Is that I tell my patients that the most important two things you can do with us during treatment is that moving and eating healthy. Okay, so moving, always do it with reason. Okay, don't overdo it. So being active is important. And for the diet, I'll say to follow the healthy diet, meaning following a Canada Health diet guidelines. This is very, I would say this is the best thing patients can do and follow during treatment and after treatment as well. Because what is the goal of all of this is to make sure that the patient have the body and the function that to develop and to improve their immune function, because they need to have a good immune function to survive through this.
Thank you.
Yeah.
Is myeloma hereditary?
Yes, that's one of the common questions we get, and they're evolving evidence. And yes, to say the hereditary part of it, it is there. There are evidence to confirm that. However, I can say not every single myeloma case it's a hereditary. Some we develop through our lifetime. Some we develop through clonal mutation, like due to exposures, some environmental exposures. Okay, and then some, yes, there can be hereditary to it.
Thank you.
Yep.
I have a lot of questions, so I think we can probably get to maybe 2 or 3 more. So let's see here. Why is it necessary to relapse 2 or more times before we can be accepted to new drugs, specifically CAR T cell transplant?
It's always in the practice, and then the approval and these medications comes from clinical trials and showing basically the evidence-based medicine. It's all the evidence that patient did respond to this and that. So for drugs that I mentioned a little bit earlier, it's start new drugs, new therapies, including CAR T, start at first as a phase 1 clinical trial. So just to use in a small number of patients who are actually advanced in their lines of therapy to see the safety and efficacy. Then phase 2, it includes sometimes on the deciding on the dosing, the number of cells of these CAR T cell, and then patients as it shows efficacy, then moves on. So for CAR T cell, now the evidence are start growing, still early on, I'd say, and basically most all these trials now, you don't see a first line CAR T cell therapy trial. You see it beyond the second line. So it cannot do a treatment that's not proven to be a good treatment as a first line. We need to see the duration longer and the efficacy and the safety for those patients. Then we'll start moving on. Okay. If I go back to 2011, 2010, the daratumumab was still in trial, and we're looking at the 3rd or 4th line therapy, and was coming slowly and showing less side effects, less problems, and have been modified and managed and treated until we see it's moving on. Now it's making its place on the 2nd line. And actually, there's new evidence now showing, wow, it could be really good also on the 1st line. So it's moving on next as well. So that's how the process goes.
Thank you. Can you address tandem autologous transplant? What are your impressions?
Yeah, tandem. It's tandem, what it means is basically we do 2 transplants back to back. We do the induction with Cyborg, then we do transplant, and then do another transplant, and then we go to the maintenance. So very selective patients. Number one, we see patients with standard risk, they do well. Patients who have a high risk, this is who we're trying to find the best treatment for them and gives them a longer progression-free survival. And there evidence now developing, and we know very well that, and there's big studies and looks in Princess Margaret in Toronto, that the patients who had tandem transplant with high-risk disease, they do well and have a longer duration compared to patients who don't do tandem. And now also international studies as well showing that as well for the high-risk patients. So when I say high risk, meaning those patients who have deletion 17p, who have the translocation 414 or 1416, those are the patients we consider them high risk, and then we'll try to get them to go to a tandem transplant. Of course, the performance status, the organ function for those patients need to be optimal so they can really do well with a tandem transplant. And sometimes we say patients get a first transplant, if they don't do well, then that's it. We cannot really take them a second transplant.
Thank you. We have time for one more question. I am a 53-year-old who's had an autologous stem cell transplant just over a year ago. What can I do to help prolong transplant success? Okay,
so basically, the number one, which is evidence-based, we have everything about it, as what I showed, to double the duration, is the maintenance therapy. Maintenance is very important for patients to keep the disease gone for as long as possible, and they surviving longer after transplant and keep this staying on. That's the number one. Number two is basically, as I mentioned, is having a healthy lifestyle, healthy diet, and also activity and being active. So these are most important. And then also follow-up, keeping close follow-up and monitoring on the lab findings.
Thank you so much for that. There are quite a substantial amount of questions. So if we did not get to your question, we will do our best to answer you offline afterwards. So thank you very much for all your questions. If you don't mind, can we put it on the before last slide?
Sure.
A few more things to talk about before we log off today. Excellent. Thank you so much. So thank you so much, Dr. Sharif, for being here today, for talking to us and sharing your expertise. It was we're all very grateful for that. Thank you. Thanks. I'd also like to thank Amgen for helping to make today's webcast possible as well. And one more slide. So before we end our webinar, I would like to remind everyone that we are here to help you. Do not hesitate to contact the LLSC if you need more information or support. You can reach us by email at canadainfo@lls.org or by calling toll-free at 1-833-222-4884. Also, make sure to check out our website regularly to watch all past webcasts or for the dates of any of our upcoming webcasts. Last little reminder is that there will be a short survey that will be sent to all participants after this webcast. We would greatly appreciate you taking a moment to fill it in, as it really helps us to offer you the most valuable information in the near future. So thank you all for joining us today. Have a wonderful day and stay safe, everyone.